Hello, everybody, and welcome to the Bad EM podcast. My name is Daniel Still, and I'm your host. Bad EM stands for Brave African Discussions in Emergency Medicine, and this is a platform we use to try and find African solutions for African problems. Welcome to Season 2, and welcome to 2025. And thanks for all the support last year and all the positive feedback, which has played a massive role in continuing the project this year. The first episode of Season 2 is one that I've been looking forward to recording for quite some time, as my guest today, Dr. Juandré Klopper, really embodies what the podcast is about, namely ordinary people trying to solve the many problems that we face in healthcare in Africa every day. We are branching out of the emergency medicine space and talking health tech, which is a hot topic globally. But the beauty of what Juandré and his colleagues at Cape Medtech do is that they are focused on adapting health tech for lower income countries that need it the most. But more of that to come. Juandré is one of the Mail and Guardian's top 200 young South Africans of 2024, and Cape Medtech was named in the top 20 small businesses in South Africa in 2024 by the National Small Business Chamber, to name but a few accolades. Welcome to the show, Juandré. Would you mind starting by introducing yourself and giving us a brief background of your career so far?
Cool, thanks Dan. Yeah, sure. I'm Juandré Klopper. I grew up in Wellington, about 45 minutes from Cape Town. And since I can remember, I wanted to be a doctor and studied medicine at Stellenbosch. Then I did my internship at Tygerberg, my ComServe in Drakenstein area. So that's the clinics of Wellington, Paarl, and Saron and Gouda. And I think this is where the story gets complicated. I think most of your guests, they're much older than I am, much more experienced than I am. I think I'm by far the most modest guest you've had. The most, I haven't had such a long career yet. I did my ComServe 2 years ago. And then while I was busy with my ComServe, I really fell in love with problem solving in the clinics. I saw firsthand a lot of things go wrong from a systems point of view, and started addressing things here and there. And before I could open my eyes, I found myself outside of clinical medicine in the startup space, and that's pretty much where I find myself now. Very unexpectedly.
Cool, yeah, thanks. I think since you mentioned your career stage and your lack of grand qualifications compared to some of my other guests, I think let's just jump ahead to a question that I'd planned for later. What do you think about qualifications in a general healthcare system in South Africa in terms of approaching bigger issues? You are early on in your career, you've spotted problems in the system that are fixable, although daunting, and you are trying to influence that from where you sit as a young doctor in South Africa without a public health specialist degree or without a clinical specialist degree. And that, I'm sure, speaks to a lot of other doctors in South Africa who want to get not necessarily fully out of clinical medicine, but want to approach something but don't necessarily feel the inherent value in spending a lot more time studying. What would you say it's important, and if so, why, and how would you circumnavigate that?
One of my wise mentors in medicine said, if you're in an OSCE and someone asks you something, always say it depends. So I think it depends. I think it depends what you want to achieve. Look, I've been very fortunate that the problems that I've encountered were in the primary healthcare setting, because that's where I was placed for my ComServe. It wasn't where I wanted to go. I had this ambition of maybe becoming a psychiatrist. I started studying for my primaries and all that. And then I found myself in rural clinics where I saw, these systems failures at times. For me, I didn't need a grand qualification, but, I'm not trying to, reinvent neurosurgical instruments. I think if you want to find a better way to do a craniotomy, you should probably be a neurosurgeon for that. I won't dabble in that. But on the topic of do I feel it's been keeping me back? Yes and no. And I'll say, let me first say this. Before I found myself full-time in the business world, so the business I started, Cape MedTech, I started that while I was still working full-time as a medical doctor. And what the business did was we started building apps to try and prevent clinical errors and also improve efficiencies in the clinics. And the plan was that I get an MO post after ComServe and keep working on the business at night as I was doing as a ComServe. As a ComServe, I was working during the day. There wasn't any money in the budget for overtime. So evenings I spent working on apps and trying to solve issues that I saw in the clinics. Basically, to get back to the question, do I feel a lack of fancy degrees have held me back? In that first bit, definitely. I told someone the other day, and this is really the truth, I ran my printer dry twice, printing CVs that I drove around Cape Town handing to hospitals. I mean, this is in addition to the many emails I've sent and many calls I've made. I tried to find a job in clinical medicine. I tried my absolute best and I didn't get a job. And that's kind of where I got to an inflection point where I asked myself, okay, good, Juandré, you had this vision of, being a doctor, making a difference through clinical medicine, and then on the sideline having your nonprofit and your startup. But that's not panning out. You're not finding a job, and I think maybe having a fancy degree would have helped me. So there's nothing, and again, at the end of the day, the degree it's about what you learn in the degree. So I mean, there's a lot of things that you learn in public health, for example, that I don't know, that I wish I knew. Just this morning, I had coffee with a friend of mine, Dr. Puni Mamdou, who's a public health specialist, and every time I talk to her, I learn so much. Things that she picked up over the years of further studying. So I mean, sure, I'm sure I would have been able to do more if I had that opportunity. But at the moment, I don't get invited to reg interviews. I haven't been called back for an MO interview. So I'm in a position where I have to make my own way and build my own path. And I don't think it's been holding me back. I've been learning a lot, but again, I've been very fortunate to have excellent mentors and a lot of people that have been able to give me free advice. And that's something I can't overestimate. It's been a very humbling journey.
Like you said, it depends on your personal journey, what you learn in a certain degree and the value that you are actually gaining from that. So it does differ a lot from person to person and the reasons you're actually doing something.
100%. And the reality is there are enough issues around us that where you are in your journey, you can start fixing problems. You don't have to wait till you're a specialist to fix problems. You don't need an MBA to start a business. You don't need a degree in engineering to figure out a system. In fact, I have been talking to a lot of biomedical engineers. I've been asked to talk to postgraduate engineering students about systems and things in the medical space. And, I thought to myself, why should a medical doctor without a degree, like in biomedical engineering, anything like that, talk to someone who's got a degree in engineering about this? And the answer is simple. We know that system so well because we've actually worked in it. So we can't overestimate the value of actually working in the system. And that is something that we have as doctors. But like I said, there's a lot that I would like to learn. I'm not someone that shoots down studying further at all. I would love to continue studying at some point in the future.
And to your point exactly, I was recently at the African Conference for Emergency Medicine in Botswana, and you bump into people that you sort of see as leaders in the field. These are hugely influential people. Very few of them took the path that I would expect them to have taken. You bump into nurses and paramedics and doctors and engineers and IT people that are all now leaders in a space where you would see yourself going, but all of them have taken their own path. So I think it's important just to realize that there are many paths you can take, and you just have to gain value out of whatever experience you are gaining wherever you are.
100% agree.
Let's talk about, so we'll get onto Cape MedTech a bit later. Let's talk about your project at the moment, Sponsor Medic. Tell us about how that idea came about and what exactly you guys do.
So Sponsor Medic, let me start by saying, there's it's no secret that we work in a very challenging healthcare system. The World Health Organization recommends that a country have at least one doctor per every 1,000 people. And then the global average is about 1.5 per 1,000 people. And I always stress this when I talk to people, that is the global average. That's not the Western world average. And South Africa finds itself at about 0.809 doctors per 1,000 people. That's very close to half the global average. So what that tells us is we are understaffed. And there are many reasons for that. And that reason spans from decades of willful resource misallocation from the previous government, spanning into a government that has to try and pick up the pieces that was broken and trying to fix the health system after 1994. And I mean, it's a very difficult task that they've been handed. And albeit, it's now 2024 and we're sitting in a situation where we still have 84% of our population relying on about, half the resources that go towards healthcare in the country, while 16% enjoy the other half of the resources. And that's obviously the private sector. So we've got this massive inequity still 30 years after democracy. And what we find, and this is no secret, is that in your public hospitals and clinics, waiting times are long. And we don't see the same level of care that we would like for ourselves. And that is because of resource limitations. And the best question to ask yourself is, would you like to go to a clinic instead of go to a GP? Or would you cancel your medical aid or your hospital plan and, go lie in a public hospital instead? I don't think a lot of people would choose that because we know that the care is substandard to what we would want. And I think the point here is that there's a quote by Dostoevsky, not to sound too pretentious, but it does sound very pretentious, but I have to say this, is this quote from him where he's in his book Crime and Punishment, where the main character, Raskolnikov, he debates morality, and he goes into this delirium, and one of the things he says is, these people have wept over it and they've grown used to it. Man can grow used to everything, the scoundrel. And that struck me so hard because, we kind of get used to the systemic failures, the issues in the system, the inequities. We witness it every day in the hospitals, we as doctors, and we kind of get used to it. We kind of get used to, yes, there's a long waiting time in the clinic. Yes, we don't have this medicine in stock. Yes, we don't have this resource available, this. And we kind of get used to it sometimes, but we shouldn't. We shouldn't get used to that. We should always strive to give better care for our patients. And what frustrated me a lot in the public health system was the lack of staff, and not just the impact that had on patient outcomes, which was evident, but also the impact that had on the well-being of other healthcare workers. It has an impact on morale, it has an impact on burnout, all those things. So for me, that's been the baseline. And then what happened about 2 years back is the news broke in a Daily Maverick article about 8.4 billion rand shortage in the wages. So this was now 2023. So what we thought to ourselves was, okay, shucks, we're sitting in a position where we're already understaffed, already underfunded, and now they're telling us the budget's going to be cut. Around that time, there were about 800 unemployed doctors because of that. So that means that apart from the fact that we are understaffed and underfunded as a country with doctors, now we can't afford to hire doctors. We've got posts frozen. We've got austerity measures.
That was 800 more than usual because
that was 800 more than usual, exactly. Yeah. And again, this was last year, January. We are now in January 2025. That number has now risen to 1,500, according to SAMA. So they just said that this week. So we're now in a position where we've got 1,500 doctors unemployed in a country that desperately needs doctors. That's almost half the global average of doctors per capita. Now, there's many reasons for this. Sorry, this is a long-winded answer to something that should have been a simple, could have been a simple question. But, there's so many layers to this. There's so many dynamics to this. But the point is, what happened was we realized that, listen, it can't go like this. We need to find a way to put more money into this. There's many reasons. There's underfunding. There's leaks in the bucket. We know that the Board of National Health Funders estimated that about 30 billion rand was lost in 2023 to mismanagement and corruption. But the reality is, even with corruption and mismanagement, all these things, the reality is that our economy hasn't been able to grow to provide the resources needed, to provide the quality of healthcare that we want to give people. We often look at percentage of GDP to compare how countries, our expenditure on healthcare. And we're always quite proud to say that, South Africa spends 8.5% of our GDP on healthcare, which is very close to European countries at 9%. But our GDP is not the same as those countries. So in the end of the day...
And our population is quite similar to a lot of them.
Exactly. So, if you look at the UK, they spend about 6 times the amount of money that we do on healthcare, and they've got a very similar sized population. Their population is about 70 million, ours are 68 million. So we're looking at a situation where it's not just that healthcare gets a smaller piece of the pie. The pie is smaller, and that's why the piece is smaller. So that's why you don't find me picketing outside the minister's house, because there's so many big issues at play here. It's not just that someone is bitter and decided to cut jobs. There's long-term economic things. And we met with National Treasury last year and had a very good conversation with Dr. Mark Pletcher, which is a really insightful person. And we were talking about some of these things. There's compounding factors. There's the fact that we're training more doctors. We're training almost double the amount of doctors we used to train, but we haven't made provision to employ more. We're paying doctors much more, even adjusted for inflation, than we did 20 years ago. All these things compound to put the government in a very difficult position. So what I thought to myself was, I was sitting in a clinic, and this comes back to that thing we were saying about you're never too small to start making a difference. I was sitting in a clinic, I didn't have an MBA, I didn't have a public health. All I had was, I'm a doctor, I know the system, I know where the issue, I can see where issues are, and I knew this was going to be an issue. So what we've done is we took some of our savings, we put it into registering a non-profit. It was a lengthy process, going through the SARS things, meeting with lawyers. We finally got our public benefit organization status, and what we've created is Sponsor Medic, which is a non-profit platform, and we're not a non-profit in the same way that a lot of I sometimes say tongue-in-cheek, we're not Doctors Without Borders. We're doctors with very clearly defined borders. We focus in South Africa, and our focus is on public health centers and clinics. So what we do is we talk to trusts, foundations, companies, philanthropists, and there are a lot of very generous companies and people in South Africa. Just this week, I had a meeting with a person who wishes to remain nameless, who's about to put 20 million into just reg training of their own money as a donation without expecting anything back. That's generous. That is generous. And there are many people like that in this country who are willing to put money into the system that desperately needs it. They just don't always know how to. And we know that there's a fundamental lack of trust in the government. And Minister Aaron Motsoaledi said this himself. He knows his department is struggling with corruption and mismanagement. That's his admission, not mine. I'm not being a whistleblower. I'm just saying what he said. But my point is, so we know that there's this lack of trust, and the only way to address that was to create a separate platform where we can ensure trust and accountability and transparency and say, listen, what we do is donors can give their money to us. We supply them with their 18A tax certificate, a BEE affidavit, all those things they need. But then we report to them in a way that government cannot report back to them. We can tell them exactly the money that you gave us was used to employ doctors so and so and so. They worked at hospital so and so and so. These are the shifts they've done. This is how many patients they've helped. And, there's a very tangible and a very real feedback loop there of the money is not going into a pit where it's vanishing. The money is going towards helping people, and they can see that and they can track that. as far as the law allows.
And I think it speaks to a problem with a lot of donors worldwide. Obviously, lack of feedback. You do your surveys, you do your needs assessments, you do all of that, and then don't necessarily know that money is being spent correctly and adequately. And there's a lot of talk now about sort of just giving and no assessments and no middlemen and things like that. But I think in South Africa, especially, there's like you said, a big mistrust of government spending, with due reason. And it's quite difficult to donate money. So hypothetically speaking, say you had a millionaire whose child had CP and had the best private treatment in the world, and they, out of their own generosity, wanted to set up a CP clinic with privately funded occupational therapy posts and physio posts and a doctor, etc., for their region. So they wanted to make a world-class cerebral palsy clinic for their region that they would fund, but it was a government-run clinic. That is a hugely difficult thing to do, and it's virtually impossible. You've told us briefly how you navigated that by setting yourselves up as a middleman, but can you expand on that problem?
Yes. It always seems impossible until it's done. They can give me a call. I welcome the opportunity. So it is difficult to give money to the government as well, and it is difficult to give donations. So that is true. When it comes to donating, for example, say I want to donate diapers to an old age home. It is a challenge because you need to have like SAPRA, proof that this is a registered, there's a quality standard for the thing that you're donating and everything. So our approach is very unique, and we've designed it in a way to make our lives easier, but also to circumvent exactly this issue. So what we've done is we've designed the nonprofit system in a way that it's very lean in the sense of we work with locum agencies that are on tender, and we work closely with the hospitals. So every hospital, I can tell you exactly which doctor I'm working with at every hospital we're supporting at the moment. If I'm talking about Mitchell's Plain Hospital, I know I can phone Roland Krokamp now and he'll answer the phone. Westvliet Hospital, I call Laverne Murphy and he answers the phone. So I have very good relationships with the hospitals. And I have good relationship with the locums that work with us and the locum agency. I work quite closely with health staff at the moment. So to answer your question, how we manage that, we don't donate the money to the government. The money doesn't go to government. The only thing that happens is the government gets the healthcare worker that they need when they need it. We pay the healthcare worker. So the healthcare worker, in essence, shows up as a locum. So, and we use the locum agencies that are on tender with government as well. So, in essence, it's just we pay the invoice for the locum that day. So, it's not that we are giving assets that have to be tracked or accounted for in their books. It's man hours that they otherwise wouldn't have gotten that they're getting. And so it's very similar to the volunteering. So, that's the other thing we're looking at. So, a lot of the hospitals, especially my poor friends that want to become anaesthetist, they sacrifice a lot of their opportunity cost to do free ICU time, and they volunteer in ICUs.
Or free anesthetics time to become an anaesthetist.
Yeah, exactly, or free anesthetics time. And so they volunteer, so they work as unpaid staff for that time, or as a supernumerary almost. So the concept of unpaid doctors working in government is not new. But we've had to work around that, not around that, but, we had to work with that and see, okay, how does this work, like, from a legal point of view? And, we started from the ground up. We started at clinics. We didn't start with the Department of Health first. Now I'm at a place where, I spoke to Minister Murray Wenger. She gave us a press release about this as well, where she's saying she's very grateful for the support we're giving them. But if I had to wait for her or anyone in the Department of Health to respond to my emails, I've been emailing a lot of them for the past year, and I haven't heard much back. But we had to start somewhere, and I hope that answers the question.
Yeah, it does. So you are not necessarily a locum agency. You still use other locum agencies, and you pay their bill.
Yes. So we as Sponsor Medic, we are a funder of health services. We are not so our main purpose, and that is why it's also helpful that we have clinical background. I'm not a specialist, but I have spent time in clinics. So what I do is I go to the clinics, I walk in the corridors, and we go and see which are the clinics that really need help. Where are places where we can help? And there's a lot of people trying to, there's a lot of people reaching out to us asking for things that does not fall in our scope and things that we are not comfortable paying for, and we tell them quite blankly, listen, that's not what we are in for. Clinics can contact us and apply, but we still vet them. We still go and see, is this something that we can be part of? Is this a facility that can really benefit and that really deserves this? Because we don't have infinite amount of money either. As a nonprofit, we've had a very generous donor last year that gave us quite a sizable donation from Stellenbosch. And, now we're in a position where we have to go find another donor. We need more funds coming in so that we can keep supporting the hospitals we're supporting. We have to keep ourselves accountable as well for how we use the money. So there's a lot of checks and balances for that and measuring, outcomes and stuff.
And then what are some of the other projects that you've done at Cape Medtech and are still looking at doing at Cape Medtech beside Sponsor Medic?
Yeah, so Cape Medtech is it really is like my little kid. It's like having a child. So Cape Medtech, we started it as a health tech startup in my ComServe. It started with apps. So I always have to preface by saying, I'm not I'm not a software developer kind of guy. I'm not the typical.
There seems to be quite a lot of blanket statements similar to that. I'm not an engineer. I'm not a software developer. I'm not a public health specialist. That.
No, really. Growing up, so I grew up in a house where my dad's a software developer. I did not like computers. I'm not one of those guys that, took IT and played around with computers. I didn't even like computer games. So for me, computers were only a utility. So, when I started my ComServe, and what happened was, the first apps I built they were built to streamline clinical decision thinking in areas where I wasn't always there. So it was like little tools for the emergency room nurses, for example, stuff like that. I didn't know how to code. I kind of had to teach myself first how to build the bike and then ride the bike in as I'm trying to ride it. So it was one of those cases. Or, you're trying to build the plane as you're falling. So Cape Medtech, it's very much, it's a real startup story. We didn't decide we want to start a business. The problems came to us, and then we built the solutions. And then my brothers came to me. My brothers are both businessmen. My dad's a businessman. So I went into medicine because I did not want to be a businessman. I was very much a reluctant businessman in the beginning. And I'm very vocal. I was very vocal about it. I kept telling people, this is not me. I don't want to be an entrepreneur. I don't want to do this. I want to be a doctor. Unfortunately, I couldn't get hired as a doctor, so I became an entrepreneur. And now it's actually turning out to be the best move my life could have taken. But anyway, but we're a real startup in the sense that we're very small, we're very dynamic. But what separates us is the fact that first we didn't start with a product and then went to find a problem that we can solve with that product. We really just sat and listened to what are the problems and what needs fixing, and then we built solutions for that. At Cape Medtech, I've limited our team to working on just 2 projects this year. Because we have a list of 10 projects and we don't have the resources to do everything. But every single one of the things we want to work on can have an impact on healthcare delivery, and we know that. We've got different provisional patent spending on devices we've developed. We've got a lot of software we've developed that we just can't roll out because we don't have the resources to do that now. And we're hoping that one day we will. But what we have enough resources to focus on 2 high-impact projects, and that's what we're working on. Then there's a third high-impact project that we really believe in, but we're just struggling to get government buy-in and traction. Let me start with that before I start talking about our big projects. Everyone who works in emergency medicine is well aware of HECTIS. Hectus is a fantastic software suite that was developed by, I think it was
Musa Parak.
Yes. Awesome software, like really changing the system.
Who, again, is not an IT developer, is not a software engineer.
I've actually met him. He's a really cool guy. And, Hectus is amazing. Hectus worked amazingly on PCs. But at the time when I was doing my ComServe, we had stage 6 load shedding, and a lot of the clinics didn't have generators. So a lot of the day there wasn't electricity for the computers to work, and we realized. And another thing was some of the clinics didn't have internet, and didn't have signal. And then, of course, the smaller clinics didn't have licenses at that time for Hectus. And then also in other provinces, they don't always have Hectus, and other countries also. So what we've done was we worked with the SATS guidelines. We built a tool that is a mobile Hectus calculator and a workflow manager. And that tool, we built that because there's studies that were done in Joburg where they showed that, the triage error rate, the amount of patients being mistriaged in South African hospitals is 31%. That's almost 1 in 3 patients that are triaged incorrectly. And the two reasons for that, the overarching reason for that is an over-reliance on manual triaging processes. And so what we've done is we've simplified it and we've removed the calculation components, and we tried to focus on the triage side, to build something that's very simple, very intuitive, offline capable, on your phone. The electricity's off, you don't have signal, but you can at least triage this patient correctly, because we realized that's a gap. And we've had conversations with the World Health Organization in Uganda about rolling this out. We've had meetings with, Royal Bafokeng Nation about rolling this out. We've had many meetings, but unfortunately, we found ourselves in a place where, we're very excited about the software we've developed and the potential that it can have, but we don't have the resources or the appetite really at the moment to take this. And we're kind of waiting to see when the appetite awakens so we can take this further. So that brings us to the 2 projects we are working on at the moment. Sorry. Again,
that's good, yeah.
You're getting a lot of long-winded answers. So the one that's our main project at the moment, and this is my big day-to-day job, is we are working on affordable hearing aid technology for South Africa. We've been very fortunate. I know in your podcast with Will from Vula, Will mentioned in his podcast he got his big injection in the beginning was from the SAB Foundation.
Yeah.
And we're very fortunate to say that last year we also got a sizable donation from the SAB Foundation for our efforts in developing affordable hearing aids. So in the world, we've got a massive problem, and that problem. We've got many problems. You can pick a problem, but one of our problems is that the global supply of hearing aids only satisfy 3% of the demand in low and middle income countries.
Wow.
So, and that is massive. That's 3% of the demand that's being satisfied. And there's millions of people with untreated hearing loss. And, hearing loss is not a sexy issue. I always say, We've been at conferences where, people talk about AI this and machine learning that, and there's a lot of sexy things in health tech. Hearing aids are not one of them, but hearing aids are crucial, and
it's an old technology.
Yes.
We just need more of it.
We need more of it, and we need it to be more affordable. It's shocking. The most affordable hearing aid on tender in the Western Cape now, it starts at 3,000 Rand on tender in government. So how the hearing aids found us, like I said, it's not a sexy problem. It found us because a clinic contacted me and said, listen, we cannot give hearing aids to our elderly anymore. We don't have the budget anymore. So again, austerity measures. So can you build something for us? Okay, now building hearing aids are a bit complex because there's a lot of regulatory things that come in. So we looked at it, and we've made great progress in this, and we are hoping to start commercializing in this year and get our regulatory approvals in this year to come. And we're hoping to start in the US and then come to South Africa purely because of regulatory reasons and the legal pathways and things like that. But the point is, we found ourselves in a position where, again, the problem found us. We didn't go out to look for a problem to fix. The problem came to us, and we're very, we can't take credit for it. But we're putting in a lot of hard work to build affordable hearing aids that we intend to push into the market. And, The thing with hearing is it's not just health tech, it's educational tech, it's disability inclusion tech, it's silver tech. Silver tech is a word that's becoming increasingly popular in the startup circles. It's referring to elder tech, basically. We've got aging populations across the world. Hearing loss has been shown to be a big risk factor for dementia and depression in the elderly. People who are already isolated, becoming more and more isolated because of their hearing impairment. And it's something that can be addressed, but people can't afford it. It's expensive. In the US, they did a survey recently, for some Americans, which is the wealthiest country in GDP per capita. It's the wealthiest country in GDP, not GDP per capita. Sorry, I'm not an economist, but I know that at least. But for GDP, they're a wealthy country. A lot of Americans, their hearing aid is their third largest purchase in their life after their house and their car. Wow. So it's something that shouldn't be that expensive. and I've got an amazing team. Darshan Naidu is my software developer, my co-founder at Cape Medtech. He comes from Takealot and Pudo, and he's a good software guy. Where we find ourselves, there's a lot of good things coming together where we can really build good tech at a good price point and really make impact. I firmly believe Cape Medtech, the way I want it to be remembered is that, it's an impact first company. We have to be profitable, but the profitability is, it's for sustainability so that we can have more impact over the long run. So with our hearing aids, we got a big investment from SAB Foundation that's going into product refinement and regulatory pathways. We're hoping to go to market in this year in the US, and then come back to South Africa hopefully next year and approach SAHPRA. So that's our big project. And then one of the things that excite me a lot, and this is something that is at SAHPRA at the moment, is our Easy Airway video laryngoscopy aids. It's something that came from my own experience in emergency medicine and also from working in hospitals. In private, if you work in a private emergency room, you often have video laryngoscopes to your disposal. When you work in private theaters, they're everywhere. Some government theaters also have them, but we don't have a lot of video laryngoscopes, and we know why. I spoke to someone the other day at Tygerberg, I'm not going to say who, but he told me that he got a quote for a new video laryngoscope. It was 90,000 Rand for a video laryngoscope for his unit. And I told him, it's sad because if I had my SAHPRA stamp, I could have sold you one for 800 Rand. And I'm not even joking, because that's...
Yeah, it's simple technology.
Exactly.
It's a screen with a video and a little camera.
Exactly.
On a different shape object than a normal video camera.
Exactly. So that's the thing. What we've done with Easy Airway is we looked at the solution on the market at the moment, which is, the all-in-one video laryngoscopes, and we decided to make it modular. And what we've seen was, especially in private, we did a lot of market research. We watched so many anaesthetists intubate so many patients. That's on top of all the patients I've had to intubate in my life. But we've noticed a lot of them don't use the hyperangulated blades per se. They use the Mac blades. And Mac blades are everywhere in hospitals. Every crash cart has a laryngoscope blade. The problem is they don't have camera on it. So what we've done is, and we've been fortunate to get IP protection and things on this, but what we've basically done was to say, listen, let's take a step back and evaluate and look at a modular approach to this. So what we've done is with Easy Airway, it's a camera unit that's designed to attach to the standard video laryngoscopes, and you plug it to your phone, and it turns your phone and a normal laryngoscope into a video laryngoscope. And we can sell that for 800 Rand a unit, and that is a tenth of the price of our of other competing products. I mean, the lower end of the market, you can get a handheld video laryngoscope for about 8,000 Rand at the moment. I think it's Medtronic. I'm not sure, but again,
is that the one with the screen on the scope?
Yes, that's the one. So they go about for 8,500, I think now. And I mean, so just that difference in price is massive. So the only problem we're facing now is that it's a Class A medical device. Unfortunately, we're still waiting for SAHPRA to give us a clarification on if they approve our status as Class A status, which has been a lengthy process, unfortunately. So even though, people that manufacture similar products have been granted the Class A status, even though in other countries this falls under Class A status, and this is all to do with the regulations surrounding the medical healthcare products. The point is, we're still waiting for SAHPRA to just give us that final go-ahead to say we can go to market. And once we have that, we can start supplying hospitals. And I get contacted quite often from hospitals saying, when can they start purchasing this Easy Airways? But yeah, so the point is to make video laryngoscopy more affordable, because we know it doesn't have to be this expensive. It doesn't have to be 90,000 Rand. It doesn't have to be 80,000 Rand. It doesn't even have to be 8,000 Rand. You can do it for more affordable. And it's because the technology has advanced to that point. But we just had to kind of wake up and realize the technology caught up with us.
Yeah, I mean, I'm often flabbergasted when I see how much medical equipment costs. You have a TV screen that you can buy at Game, and it's a very reasonable price. But then if it's a medical grade TV screen, all of a sudden it's like thousands and thousands of rands more. Also, I've always been, just as a complete side note, those smart dummies that you do courses with. Yeah. The ACLS dummy that can speak and has a heartbeat and stuff. I mean, it's impressive but it's like a very simple thing made out of plastic and tubes that you can plug into a machine and give you a rhythm. And then it costs like 500,000 Rand.
Yeah, I was just about to say 500,000 Rand, you expect it to have a Porsche logo on exactly. And 4 wheels. And wait till you find out what an operating theatre table costs.
It's ridiculous. But it speaks to what you're saying. You need to, so a large part of your company is making medical grade technology cheaper to offer a much needed service to a lower income environment like South Africa and the rest of Africa. And that speaks to what you're saying, and what everybody's trying to do is try and adopt first world standards of medical practice and medical technology into a realistic, sustainable African setting, which we can realistically work with. Yeah,
and my surname isn't Rupert. My surname isn't Oppenheimer. My surname isn't Mutsepe. At Sponsor Medic, we are able to channel resources. But at Cape Medtech, we have a different approach. We're saying, look, we have an amount of resources in South Africa. We've got a certain amount of input. We need a certain output. The only thing we have control over here is how we use those resources. I often reference Archimedes, who famously said, give me a lever long enough and a fulcrum big enough and I can move the world. Yeah. And it's all about a different approach to something. Like it's about what you do in the middle. It's not necessarily how much force you put in or how big or how small the object is you need to move. It's about how big that lever is and how you position these things on the lever. And so for me, that's where systems come in. And I really love problem solving in this space. These challenges of, listen, we can't always just put in more resources. We can't just give government the money to necessarily buy, 100, 80,000 Rand CMAC machines, but we can make a video laryngoscope that's much more affordable for them so that they can afford 100 of that. So it's all about finding ways to get more for what we can put in. And that's my passion.
Almiro, who was in the first season of the podcast, he often said to me that if you want to undertake something that is sustainable, it doesn't have to be perfect, like a CMAC machine, or not that a CMAC machine is perfect, but it's a very nice machine. It doesn't have to be perfect, but it has to be better than what you've got. And that is something that we can strive for, is improving on what we currently have, which is no video laryngoscopes.
Yeah, 100%. I often do consulting with other companies at the moment. And I found myself deeper and deeper in this rabbit hole of business development and things. And one of my things that I often tell people is the biggest enemy of progress is perfectionism. There comes a point, and I mean, Almiro and I, we've had plenty of conversations, and I really admire him, and I definitely agree with him on that. Van Gogh famously said, great things are done when a lot of small things are put together. Like, it's a bunch of small paint strokes that make the big painting, that make the big masterpiece. So even if you can't see the big painting already, where you are, you can start making a difference. You can start painting, and that it forms part of a bigger picture.
There are obviously a lot of things that you would wish for. If you had a magic wand and could wish for one thing to materialize in South African healthcare tomorrow without concern of budget or barriers or anything like that, what would that be?
There's a few things I can think of, as you said. At the end of the day, what I want to see is everyone have access to high quality, equitable healthcare, equal healthcare. How we get there is going to be a challenge. If I could just flick my fingers, that's what I would want. But I often tell people, inequality is a given in a free market. The difference between someone having an iPhone and someone having a Xiaomi phone, that is acceptable. The difference between someone having access to dialysis and someone having not access to dialysis, that for me is unacceptable. There's a difference when it comes to healthcare. There's a difference. Inequality in healthcare is not the same as just inequality. It's a right. It's life and death. So that's something that I'm very passionate about. And that's why it often surprises people when I say I'm very scared of NHI and the way NHI is being tabled, because people always say, but Juandré, you're so in favor of health equity and equality in healthcare. How can you criticize NHI? Well, it's not that I have a problem with the intent of NHI. I have a problem with it in the way they're doing it.
Yeah, well said. That's a different conversation for a different day. But I would 100% agree. I think there's wonderful intent, and the reasons behind it are hugely valid. But also, it's a process in itself. It's a problem it's not a problem. It's a bill or a law that will very slowly come into effect, and I don't think a lot of South Africans fully comprehend that. They sort of think it's going to start on a certain date and pandemonium will break loose because they can't go to hospital anymore. It is something that will roll out with different packages and different funding structures for different problems at a very slow pace.
Definitely.
Yeah, I'm sure a lot of, especially junior doctors in our age bracket, look up to you and look at the work that you're doing and are very inspired by that. So congratulations for that. And you have given a lot of inadvertent advice throughout the podcast. But if there's one thing you could sort of, as a send-off, say to anybody who's looking to expand into a health tech or entrepreneurship or even just a non-clinical workspace as a young doctor. I mean, South African doctors, based on really what we have to do to get into a medical degree, there's a lot of potential. So what would you advise on junior doctors to try and channel that potential?
So first off, I'm very flattered that you say that people might be inspired by me. There are much more inspiring and more worthy people to look up to. So my first advice would be go find someone else to look up to. I'm just a guy trying my best. So my advice, so there's two things that I think is important that if I can go back in time and just reaffirm to myself, it's this. The first one is this: no matter where you are, you can start making a difference. And making a difference it's not like a academic exercise, a quality improvement PowerPoint you have put together and this and this and this. Yes, it can take that form, but it's incremental changes. It's where you are, you can start making changes that have impact. I'm not a big fan of the typical startup motto of you have to disrupt things. I don't believe in disrupting things. I believe in improving things that are there, not disrupting things. So where you are, see where you fit into the system and where you can make a difference for one patient at a time, one person at a time. At the end of the day, we as clinicians, we owe it to our patients. We are our patients, and we are more to our patients than doctors. We're advocates for our patients, and it's an absolute privilege and an honor to have, but it is a bloody scary responsibility to have as well. And it is bloody scary. The other thing that I would say as advice is the grass is not greener on the other side. A lot of people want to leave clinical medicine because they may be burnt out or, and I get that. Clinical medicine, I miss it often. It's not necessary. It's not easier to be in the business world than it is to be a doctor. I think it depends on the person. For me, it's very far out of my comfort zone. There's a lot of things I took for granted in medicine. Having a salary every month, that is massive for your psychological well-being. Being in a business, I can't remember the last time I don't even get close to what I used to get as a first-year intern. I mean, the first salary I got was, I don't want to say how much I'm getting now, but let me just say, I really miss even an intern salary. So, because when you're building a business, you sacrifice, and you have to invest in your business. You have to invest in your business before you can expect someone else to invest in your business. And yes, we got R1 million investment here, and yes, we got a donation of this. There's a lot of money coming into the business, but that's not your money. It's the business's money. It's the money that's going towards the mission. It's not the money going towards your holidays. Yeah. So it's a lot of sacrifice. It's a lot of putting in, and I work very hard. I'm not going to lie. When you work for yourself, there's only one type of leave, and it's unpaid leave. So, it's tempting to think the grass is greener on the other side, but don't go into it if it's not really what your passion is and what it is that you want to do, because it's not necessarily easier. And it's not necessarily nicer. There's a lot of things of clinical medicine that I really miss, and I really, don't take it for granted. But also, if your heart is being pulled towards this, and this is really what you're passionate about, and this is where you feel you can make a bigger impact, jump in it, go for it. And if you're unemployed, I was also struggling to find a job somewhere. I started building the raft where I was and started sailing it. And the thing is, take responsibility. Start building things. Start building solutions. And not everyone should be an entrepreneur. Not everyone should, build a company or whatever. But don't be a victim of circumstance. Every man is a captain of their own destiny, a la Dead Poet Society. At the end of the day, find what you're passionate about and start building towards it, and pick up the tools and start building.
Awesome. Well, yeah, thank you so much for joining us, and good luck with all of your next endeavors over the year, and all the more in the future. You've got a long road ahead, but it sounds like you've made a good start.
Thanks, Dan. And it was really nice meeting you, and thanks for the podcast. It's really awesome.
All right. We hope you enjoyed that conversation with who I certainly think is a very inspiring young visionary in the field. Just to recap the episode, we chatted about Juandré's lack of qualifications and his perspectives on what that means in different situations, specifically what you want to achieve with a certain qualification you're doing. We then spoke about some of the challenges when it comes to setting up NGOs and the intricacies of donating money and working with the government. We covered the wonderful work that he's doing at Sponsor Medic and Cape Medtech. I've also put links to their websites in the show notes, as well as a link to Juandré's LinkedIn profile. So should you or somebody you know want to get in touch, then head over there. In another matter, if you have done or are interested in any pre-hospital research, be sure to join the Western Cape EMS at their annual research day coming up on the 12th of February at Groote Schuur Hospital. I have put links in the show notes, both for attending and contributing to that. Right, and that's all for this month. Be sure to review and subscribe on all of your main platforms, and send to a colleague or friend who might be interested. See you next month. Bye bye.